Welcome to the Explainer. Today, we're digging into the brand new 2023 ACG guidelines on celiac disease. Think of this as your clinical cheat sheet, all the latest, most practical recommendations that you can start using with your patients right away. So, why all the focus on celiac? Well, look at this number. This condition is way more common than you might think, affecting nearly 1% of the population here in the US. That means, statistically, you're absolutely seeing these patients, whether they have a diagnosis yet or not. Okay, let's just quickly make sure we're all on the same page. The official ACG definition is so important because it really frames this correctly. We're not just talking about a gut problem. It's a permanent, multi-system, immune-mediated disorder. And that mental shift is absolutely key to recognizing just how many different ways this disease can show up. So here's our game plan. We're going to walk through the entire clinical journey, starting with who to test and how, moving on to locking in the diagnosis. Then we'll cover management and long-term goals, and we'll finish up by tackling some of those tricky clinical questions that always come up. All right, let's jump right in. We're going to start with the first, most critical question any of us faces in the clinic. Who should we actually be testing for celiac disease in the first place? I mean, with potentially millions of Americans walking around with celiac, you've got to have a smart strategy, right? You can't test everybody. Luckily, the guidelines are super clear on how to improve our detection rates without going overboard. And here is the single most important takeaway. The ACG strongly recommends a case-finding strategy. We are not doing mass screening. The whole idea is to be targeted, to be strategic, and to focus our testing on those individuals who are in high-risk groups. So what does that look like in your clinic day-to-day? Well, it means you have to keep a really high index of suspicion. Of course, you're thinking about it in patients with classic malabsorption symptoms. But the guidelines push us to look for those more subtle signs too, like unexplained iron deficiency anemia, or premature osteoporosis, or even those persistently elevated liver enzymes that you can't figure out. And of course, a first-degree relative with celiac, that's a huge red flag. Okay, so you found a patient you want to test. The algorithm from here is actually pretty simple. You start with a TTG-IgA test, but, and this is critical, you have to get a total serum IgA at the same time to rule out a deficiency. If they are IgA deficient, you just switch over to your IgG-based tests. And if that serology is positive, your next step is usually an EGD to get biopsies for confirmation. So let's follow that path. Your patient's serology came back positive. Now what? How do we definitively confirm this diagnosis? Because this is where the role of the biopsy is really starting to evolve. Now, this is probably one of the biggest practice-changing areas in these new guidelines. For decades, the answer to this question was just a simple yes. But now there's a whole lot more nuance, especially when we're talking about our pediatric patients. For most adults, let's be clear, the answer is still yes. An EGD with multiple biopsies from the duodenum is still the gold standard. But, and this is a big deal, the guidelines are now formally suggesting an alternative path, a non-biopsy diagnosis based only on serology for a very, very specific group of kids. And if you are doing that biopsy, your technique matters a lot. The guidelines are very specific. You need to get multiple samples. The recommendation is 1 to 2 from the duodenal bulb and at least 4 from the distal duodenum. This is so critical because the disease can be really patchy, and taking this many samples gives you the absolute best shot at catching it. Okay, so what about this non-biopsy option for kids? Let's just say the criteria are incredibly strict. You need a TTG-IgA level that is sky high. We're talking more than 10 times the upper limit of normal. And that's not all. You also need a positive EMA antibody test from a completely separate blood draw. This bar is set so high for one reason, to prevent misdiagnosis. So, once you have that diagnosis confirmed, we start the lifelong journey of management. And the cornerstone, of course, is a strict gluten-free diet. But what are we actually trying to accomplish here? What's the real therapeutic goal? Well, the primary goal is pretty simple. We want to resolve the patient's symptoms and get their antibody levels back to normal. But the guidelines are really pushing us to think bigger. They're suggesting a long-term goal of complete mucosal healing, meaning we want to see that small intestine recover on a histologic level. That's what we think really improves those long-term outcomes. And remember, this is an ongoing process. That first year is so important, with a check-in around 3 to 6 months. After that, annual follow-ups are pretty standard. And look closely at that 2-year mark. This is where it's recommended to consider a follow-up biopsy in adults to actually see if we've achieved that mucosal healing we were just talking about. All right, in our last section, let's tackle some of those common, sometimes challenging clinical questions that always seem to come up in practice, and we'll get clear answers straight from the ACG guidelines.
Yes, the classic oat question. This has been a point of confusion for so long for both us and our patients. The advice has been all over the map for years.
Well, the 2023 guidelines give us a nice, strong recommendation. Yes, patients with celiac can eat gluten-free oats. Now, the key clinical takeaway here is that a small number of patients might still react to the oat protein itself, so you have to monitor your patient for tolerance after they start eating them. You know, this next question really highlights the fact that celiac isn't just a GI disease. It makes you wonder, are there other preventative care measures we should be thinking about for these patients? And the answer is yes. The ACG suggests pneumococcal vaccination, and this is such a great clinical pearl. The reason is that up to a third of adults with celiacs can have something called hyposplenism, putting them at a higher risk for infection from certain bacteria. So this is a really important one to remember. Okay, here's a very modern-day question. With all this new health tech out there, patients often come in and ask about these portable gluten sensors. Can these little gadgets actually help them stay safe?
And on this one, the guidance is really clear. The ACG suggests against the routine use of these devices. Why? Well, there are real concerns about their accuracy, both false positives and false negatives, and there's just no data to show they actually improve how patients do. The standard of care is and remains expert counseling from a dietitian.
And that brings us to our final thought. As these guidelines embrace a future with less reliance on biopsies, especially for kids, it raises a really fascinating and critical question. If our ultimate goal is mucosal healing, how are we supposed to assess that in a patient who never had a baseline biopsy to begin with? It's a challenge that really shows just how dynamic and how fast the management of celiac disease is evolving. Definitely something to think about.